Good day and welcome. My name is Mark Pegram from Stanford University. I'm pleased to moderate this session on the year in review for breast cancer. I'm delighted to be joined by expert panelists. I'll allow them to introduce themselves in turn right now.
My name is Foluso Ademuyiwa. I'm an associate professor from Washington University. I'll be talking about triple-negative breast cancer.
Hi, my name is Keerthi Gogineni. I am faculty at Emory University, and I'm going to be talking about hormone-positive breast cancer.
Hi, my name is Valerie Mitchell. I'm a patient advocate, and I'll be sharing a little bit about my journey through breast cancer.
Thank you all for joining the program today. Looking forward to hear your presentations, and special thanks to our sponsor today, Total Health Conferencing, for helping the faculty get all of their slides together for your consideration. I'm going to lead off the discussion today talking about management options in HER2-positive metastatic disease. My disclosures relevant to topic are shown for your consideration. In the short amount of time allotted for this exercise, I'm going to have to stay focused for my presentation on overview of recent data, particularly drugs that have recent new drug approvals by the FDA, with updates from ASCO 2020 and ESMO 2020 as well. I'm going to focus on efficacy, safety, dosing, and guidelines for these new agents recently approved. And then in the time remaining, I'll have a brief comment about future directions and considerations of an Fc domain engineered antibody called margetuximab. First, I'd like to start off this discussion to tell you about a small molecule pure HER2 kinase inhibitor called tucatinib. And as you can see from the figures, tucatinib has a structure which only allows it to interact with the HER2 kinase domain, whereas it cannot interact with the EGF receptor kinase domain. And that distinguishes tucatinib from lapatinib or neratinib, which have broader activity against both kinases. And as a consequence of lapatinib and neratinib perturbing the EGF receptor kinase domain, it has EGF receptor-like toxicities, such as cutaneous rash, diarrhea, etc., whereas it is hoped that tucatinib, being a more pure HER2 kinase inhibitor, it will have fewer off-target toxicities due to EGF receptor signal perturbation. So tucatinib is a reversible kinase inhibitor that distinguishes it from neratinib, which is irreversible. It's over 1,000 times more selective for HER2 than EGF receptor in vitro. Benefits of tucatinib have been demonstrated in vivo models, including breast cancer, as well as intracranial xenograft models. And preclinical and clinical studies have demonstrated that tucatinib and trastuzumab together are synergistic compared to either agent alone. And there's highly selective inhibition of HER2 that may improve tolerability, at least in theory. I'd like to go directly to the FDA registrational pivotal trial of tucatinib, which was a randomized, double-blind, placebo-controlled, active comparator phase 2 trial called HER2CLIMB. This involved patients with HER2-positive metastatic disease who had had prior treatment with trastuzumab, pertuzumab, and T-DM1. So a heavily pretreated population in terms of prior exposure to common HER2 targeting agents. Very good to excellent performance status. Brain metastasis were allowed. Not only stable treated brain metastasis, but also untreated brain metastasis that did not need immediate local therapy, or previously treated metastasis not needing immediate local therapy also. So this is a very unique study design that allowed both stable brain mets as well as active brain metastasis in the eligibility, and almost half the patients in the study did have brain metastasis. I'll show you that subset analysis shortly. The randomization was to placebo plus trastuzumab plus capecitabine at 1,000 milligrams per meter squared, standard doses and schedules of IV trastuzumab, or trastuzumab and capecitabine in the same dose and schedules, along with tucatinib at 300 milligrams PO BID. The baseline characteristics in the study were well balanced for age, ECOG status, de novo stage 4 disease, hormone receptor status, prior lines of therapy, and brain metastasis. There were 612 patients enrolled. The primary endpoint was progression-free survival among the first 480 randomized patients. The sample size was expanded by protocol amendment during the conduct of this randomized trial to allow more statistical power for the secondary endpoints, which are shown on the right lower part of the slide for your consideration. And finally, the study was stratified by presence or absence of CNS metastasis, ECOG status, and world region, US, Canada versus rest of the world. These are the top line data. The primary endpoint was progression-free survival. The Kaplan-Meier analysis is displayed on the left-hand side of this slide. As you can see, the progression-free survival favored those patients who were randomized to tucatinib as compared to placebo in combination with trastuzumab and capecitabine. The hazard ratio for the benefit of tucatinib in this study was 0.54, and these results were highly statistically significant with 4 zeros after the decimal point on the p-value. On the right-hand side of the slide is the forest plot subgroup analysis showing a high degree of consistency in this data, indicating the robust nature of this pivotal phase 3 trial. The PFS population is at the top for comparison, and the gray line, the gray box, indicates the 95% confidence limits around the intent to treat population point estimate on hazard ratio. So you can see that irrespective of age, race, hormone receptor status, presence or absence of brain metastasis, ECOG status, or world region, the data were highly consistent. All of the point estimates on the hazard ratios were to the left of unity, and all of the confidence limits comfortably overlapped that of the PFS population in total. So on the basis and the strength of this very robust data and primary endpoint, as well as some of the key secondary endpoints I'll show you momentarily, the FDA granted approval of tucatinib based on the HER2CLIMB study. And the label indication is shown at the bottom of the slide for your consideration in quotes. Tucatinib is a kinase inhibitor indicated in the combination with trastuzumab and capecitabine for the treatment of adult patients with advanced unresectable or metastatic HER2-positive breast cancer, including patients with brain metastasis who have received one or more prior anti-HER2 based regimens in the metastatic setting. So the FDA specifically called out the brain metastasis subset, even in the label indication, and I'll show you data to support that, that statement. Moreover, the overall survival endpoint was met with statistical confidence at the time of this first planned interim analysis of the HER2CLIMB pivotal trial. As you can see, the overall survival significantly favored the tucatinib randomized subjects with a hazard ratio of 0.66 and a p-value of 0.0048, indicating a 34% reduction in the risk of mortality, favoring the tucatinib experimental arm as compared to control. So again, very impressive overall survival signal in this data set, especially considering the prior treatment with pertuzumab, trastuzumab, and TDM1 prior to study entry, which all the patients in this study had. Now at ASCO, Dr. Nancy Len from Dana-Farber showed a very interesting update on the subset of patients who had brain metastasis that were enrolled in the study. And it was about 48% of the patients enrolled in the study indeed. So on the upper left, to begin, this is a Kaplan-Meier analysis showing an overall survival benefit in patients with brain metastasis as a whole. The hazard ratio for the benefit of tucatinib in the subset with brain metastasis of any type was 0.58. P-value was significant, 0.005. So remarkable data. The risk of mortality was reduced by about 42% in the subset of patients with brain metastasis. On the lower left-hand Kaplan-Meier analysis, this is the CNS PFS benefit in patients with stable brain metastasis. It also was statistically significantly superior, favoring the tucatinib-treated patients as compared to placebo when combined with trastuzumab and capecitabine. The hazard ratio in here was impressive, 0.31, again, statistical confidence with a p-value of 0.002. The risk of CNS progression or mortality was reduced by 69% in this subgroup. On the top right-hand side of this slide is the overall survival analysis in patients with active brain metastasis. And even this difficult to treat high-risk subgroup had a significant benefit from tucatinib with a hazard ratio of 0.49, p-value of 0.004, indicating a 51% reduction in risk of mortality, favoring the tucatinib randomized subjects. So a very impressive subset analysis, even in patients with active brain metastasis. And finally, on the bottom right-hand side of the slide is the overall survival in the subset of patients with stable brain metastasis. The hazard ratio here was 0.88. It did not rise to the level of statistical confidence. However, note the smaller sample sizes in many of these subgroups. So many of these subgroups lacked statistical power to show a significant benefit, even if one may exist. Moreover, we probably need more time to let this data mature to see if an efficacy signal here may mature with time and become positive. It's probably too early to tell. But nevertheless, considering so many different subsets, it's remarkable how many of them return significant, given the fact that they're relatively underpowered for the OS endpoint. Now, this is new data that was just presented at the ESMO 2020 meeting. This addresses a key important question that often comes up amongst clinicians as to whether these small molecule HER2 kinase inhibitors can prevent brain metastasis progression. And so they looked at this metric, a very interesting metric of new brain lesion-free survival probability, shown by Kaplan-Meier analysis in the center of the slide. And as you can see, there was a superiority in the tucatinib-treated patients compared to placebo for this particular metric, with a hazard ratio of 0.5 and a significant p-value once again, indicating a 40% reduction in new CNS lesions or mortality in patients with or without brain metastasis in the tucatinib arm. So again, this is really remarkable, and it's consistent with a hypothesis that maybe you can delay the onset to new brain lesions in patients treated with tucatinib with HER2-positive brain metastasis. And if so, that could be a really critical quality of life endpoint from my point of view, because whenever you see a new CNS progression event, that usually means more stereotactic radiotherapy or even whole brain radiotherapy, both of which cumulatively eventually can result in significant cognitive impairment due to radiation toxicity in the brain. Also, sometimes these patients may be even candidates for neurosurgical procedures for debulking in symptomatic cases if they're surgically approachable. So, you know, those types of interventions and the consequences and complications of those interventions have a deleterious impact on quality of life, hypothetically. So if you can delay or prevent the onset or the need to treat new brain metastasis, that could be an important therapeutic advantage, in my opinion. In terms of safety signals in greater than or equal to 20% of patients, you can see that tucatinib is very definitely associated with a higher risk of all grade lower GI toxicity, pulmonary-plantar erythrodysesthesia, upper GI toxicity in the form of nausea or vomiting, also some increase in stomatitis, and also transaminase elevation, as well as a little bit of anorexia. Fortunately, most of these increases are in the grade 1 or 2 level. However, there are some that have grade 3 increases compared to control as well, particularly the diarrhea and the PPE syndrome and the transaminase elevation, all of which merit careful attention if you choose to use the HER2 regimen for your HER2-positive metastatic patients. One last comment about safety, since this comes up frequently. It turns out that the alopecia risk for the HER2 regimen was 4.7% in the published data for the HER2 study in the tucatinib-treated patients. So this regimen has a low risk of alopecia, which is another important endpoint for many of our patients. Next, I'd like to change focus for a little bit and have you consider a new HER2 targeting antibody drug conjugate, trastuzumab deruxtecan, formerly known as DS-8201, has the same amino acid backbone sequence as trastuzumab. And there is a tetrapeptide cleavable linker conjugated to cysteine residues at 8 cysteines that are in the trastuzumab backbone antibody structure. And the payload is very interesting. It's a topoisomerase 1 inhibitor, a exatecan derivative. And this is a soluble payload that actually has a bystander effect. In other words, it can diffuse to adjacent tumor cells that haven't been yet bound by the antibody drug conjugate, and it can kill those cells in trans, because this has a payload that is soluble with a bystander effect. And that's in contrast to TDM1, which has no measurable bystander effect in laboratory models, for instance. So the number of cysteines to which the topo-1 inhibitor payload is attached is 8. Therefore, the drug to antibody ratio is 8. That's higher than TDM1, which is about 3.5 on average. And so the linker and the payload here are also very potent. So that may account for its robust clinical activity. This agent was tested in the phase 2 non-randomized Destiny Breast 01 open label multi-center trial. The primary endpoint of the study was the objective response rate in patients in the study who received the study drug at a dose of 5.4 milligrams per kilogram. There were other dosing cohorts in the study that I'm not showing you in the interest of time. They are in the published manuscript shown in the reference at the bottom, published by Modi and colleagues in the New England Journal of Medicine earlier this year. As you can see by the waterfall plot on the right-hand side of this slide, there was a very robust efficacy signal with a objective response rate of over 60%. It was I believe 60.9% in this series. And consider the fact that this is such a high response rate in this population of patients enrolled in the study that had a median of 6 prior lines of therapy. So this is a very, very heavily pretreated population. To have this kind of efficacy signal in the salvage setting is extraordinary. So based on this data, we can safely say that trastuzumab deruxtecan is the most active single agent HER2 targeting drug that has yet been developed. There was also a 6-month clinical benefit rate, which includes CRs, PRs, and stable disease for at least 6 months, that was 76.1% in this population. In terms of the subset analysis, once again, the all patient population is shown at the top, and you can see that the confidence limits around these point estimates on the objective response are comfortably overlapping the all patient population. Notice that the brain metastasis population did fare well, although with wide confidence limits. There were 24 patients with brain metastasis enrolled in the study, and their objective response rate was very similar to the intent to treat population, and their median PFS was also very similar to the intent to treat population as well. So again, consistency of data. The one outlier that is of some interest perhaps is that the IHC 3+ group had a non-significant trend that appeared a little bit better than the IHC 1+ or 2+ that were FISH positive. But once again, the overlapping confidence limits indicates that this sample size is too small and lacks statistical significance and is exploratory in nature in terms of any conclusions to be reached on the basis of subset analysis. Next, I'm showing the progression-free and overall survival on the left and right-hand sides of the slide, respectively. The median PFS was 16.4 months in this trial. And among the 24 patients with brain metastasis, it was 18.1 months, once again, as I mentioned, with wide confidence intervals. But still, considering this heavily pretreated population, to have a median PFS of well more than a year is extraordinary. Moreover, the overall survival signal so far is truly remarkable. You can see the months of follow-up at the bottom out to 20 months on this particular plot. And you can see the median has not been reached. It's not even close. And in my opinion, to see this kind of lengthy overall survival in a salvage setting after so many rounds of prior therapy is unprecedented, truly. So this is a very, very active agent in terms of efficacy. Now, there are concerns with regard to safety of this agent, in particular, an adverse event of special interest, and that is interstitial lung disease. Among the 25 patients who had ILD events, you can see the breakdown in terms of grade 1, grade 2, grade 3, et cetera. And sadly, on this trial, there were 4 patients who had grade 5 interstitial lung disease. So this is something that has to be taken very seriously by clinicians now that this drug is approved. And so you need to monitor very carefully for signs, symptoms, physical findings, or radiographic evidence of interstitial lung disease. This tended to occur late with a median time to investigator-reported onset of 193 days. So don't be lulled to sleep if you have a patient who's made it out 2 or 3 months and has had no ILD event. You still need to monitor them with the same enthusiasm. Some of the patients had glucocorticoids. Many of the patients did recover or were recovering, especially the lower grade adverse events. Some were still in follow-up. And as I mentioned, 4 had succumbed to their complication in this trial. The onset for the fatal cases was between 63 and 148 days, and mortality events occurred 9 to 60 days after the ILD diagnosis. 3 of those 4 had steroids. So the recommendation is to monitor for symptoms, hold the drug, start steroids immediately if you suspect ILD for grade 2 or above, and consider it for grade 1. So here's an algorithm for the workup of interstitial lung disease for trastuzumab deruxtecan. If it's suspected, interrupt the drug, do further workup, signs, symptoms, radiographic assessment, pulmonary consultation, rule out infectious complications, consider pulmonary consultation, perhaps even bronchoscopy with bronchoalveolar lavage if it's clinically indicated. There may be other pulmonary function tests to consider, diffusion capacity of carbon monoxide, DLCO, for example, pulse oximetry, PFTs, et cetera. And the bottom line here is if there's resolution within 28 days, then you can safely resume and maintain the dose. However, if it takes longer than that, even for a grade 1 event, you are to reduce the dose by 1 dose level from 5.4 milligrams per kilogram down to 4.4 milligrams per kilogram. And if grade 2, that is symptomatic ILD occurs, you are to permanently discontinue treatment and treat with steroids. These are other adverse events in the overall population. You can see that this drug, in contrast to TDM1, has more chemo-like side effects. This side effect profile is reminiscent of topoisomerase 1 inhibitors given as parenteral agents, for example, topotecan and irinotecan. So nausea, fatigue, alopecia in almost half, some vomiting, constipation, cytopenias, diarrhea, thrombocytopenia, headache, etc. So be mindful of this and don't advise patients that this will be just like TDM1. It's a really different drug. It's a different payload. It has different attributes, different safety signals. So you must be mindful of this so patients know what to expect. And also prophylaxis is warranted for GI, upper GI toxicity, in my opinion. I usually treat patients with antiemetics routinely prior to administration of this agent. Finally, I'll finish up with a brief introduction to you about some antibody engineering that I find very, very novel and innovative. Using a yeast surface display technology, investigators at Macrogenics identified 5 key point mutations that could be introduced into the FC domain of HER2 antibodies, which increases the affinity for activating FC gamma receptors on NK cells and decreased affinity for decoy inhibitory receptors on NK cells. And as a consequence, there's enhanced and more potent antibody-dependent cell-mediated cytotoxicity with this HER2 antibody called margetuximab as compared to trastuzumab. And so this paradigm and mechanism of action set the stage for a head-to-head comparison of margetuximab versus trastuzumab, combined with chemotherapy of investigator's choice, either capecitabine, eribulin, gemcitabine, or vinorelbine. And that way, we could really see what the impact of this engineering of a HER2 antibody might afford. So these were HER2 positive advanced breast cancers with 2 or more previous anti-HER2 therapies, including pertuzumab. 1 to 3 prior lines of treatment for metastatic disease was required for eligibility. Prior brain metastases were allowed if they were stable and treated. There were 536 patients randomized. The primary endpoint was PFS and a dual co-primary endpoint of OS as well. Secondary endpoints included objective response rate by central blinded analysis, investigator assessed PFS, and there were exploratory scientific tertiary endpoints, especially looking at some genotypes of FC receptors that have low affinity or higher affinity for the FC domain of trastuzumab. These are the top line data as of last September 2019 cutoff. The investigator assessed PFS is shown by Kaplan-Meier analysis on the left. there was a 29% reduction in the risk of disease progression with a hazard ratio of 0.7 with statistical confidence. However, at the median, the absolute benefit was modest, just over a month indeed. And so that raises a question, does this modest benefit in an intent to treat population merit consideration for regulatory approval or not, and consideration in the clinic or not? That will be up to the FDA later this year. There has been an interim overall survival analysis. 2 planned analyses have occurred. The overall survival analysis now has a hazard ratio of 0.89, but it is not yet statistically significant, and more time will be needed to collect more events to see whether that could become significant in the future. Time will tell. On the right-hand side of the slide is one of these exploratory endpoints looking at these lower affinity Fc gamma receptor genotypes that have a little bit worse prognosis when treated with trastuzumab. And interestingly, margetuximab does have a numerical advantage, at least in terms of overall survival, in this subset of patients that have these low affinity genotypes that have phenylalanine substituting for alanine at CD16A. I'm sorry, phenylalanine substituted for valine at position 158 in the CD16A gene sequence. If you look at the FF carriers, this difference is even more marked, but that's a minority of the population. All F carriers in total is about 85% of patients, but the FF genotype is only in about 15% or so. But that is another group of particular interest. This difference with a hazard ratio of 0.79 in the F carrier group was marginally significant only, with a p-value of 0.087. So it didn't rise to significance with a p of 0.05 or less. But an interesting observation. In conclusion, tucatinib has many strengths. It's orally bioavailable, HER2 selective. HER2 met its PFS, OS, and PFS in the CNS metastatic subgroup with statistical confidence at the time of the first planned interim. It's approved as second or greater line therapy by the FDA, including patients with brain metastasis. There's a low risk of alopecia, a low discontinuation rate. There's no box label warnings on the package insert, and has a proven overall survival benefit and publication in the New England Journal. There are some weaknesses with tucatinib. The BID dosing schedule is sometimes problematic in terms of compliance. It is a 3-drug regimen, one of which is parenteral. It can cause significant diarrhea. It can cause significant hepatotoxicity. Need to be mindful of these. Monitor the liver function tests is a requirement. And then you have to watch out for drug interactions with this agent as well, particularly for CYP3A interacting drugs, CYP2C8, or P-glycoprotein interacting co-medications. Finally, one may observe a reversible increase in the serum creatinine in these patients treated with tucatinib. It is not an impact on renal function. There's no change in the glomerular filtration rate, but rather simply a change in renal tubular transport of creatinine caused by tucatinib. So you don't need to refer these patients to neurology. Conclusion 2, trastuzumab deruxtecan. Its strengths include being the most active single-agent HER2-targeted therapeutic yet developed, has a high drug-to-antibody ratio, a payload with a bystander effect, and has activity in tumors that aren't even HER2 3+, lower IHC HER2 that are FISH negative in early trials had an efficacy signal. It's been approved under an accelerated approval basis by the FDA based on response rate, duration of response, and the trial winning FDA approval is published. Weaknesses: original FDA approval is based on the non-randomized data, since this is an accelerated approval pathway. So as yet, there's no level 1 evidence of benefit yet in the CNS metastasis group. Future trials will need to be conducted to look specifically at HER2-positive brain mets with this agent. It does have some chemo-like toxicities, nausea, vomiting, diarrhea, alopecia, cytopenias, etc. And there is a risk of interstitial lung disease that one must be mindful of. Finally, in terms of a clinical pearl, if you have any symptomatic grade 2 or greater ILD, you are to permanently discontinue trastuzumab deruxtecan and treat with steroids at a dose of 1 mg per kg of prednisolone or its equivalent. Finally, margetuximab is an Fc-engineered chimeric antibody with enhanced immune effector function, with the same specificity and affinity to HER2 as trastuzumab, with similar ability to disrupt signaling, no increase in cardiotoxicity, low drug discontinuation rate. The weaknesses of the data: Though statistically significant, the improvement at the median was small, 5.7 versus 4.4 months for margetuximab and trastuzumab plus chemo, respectively. There was an increased incidence of infusion-related reactions also in the margetuximab arm, 13.3% all grade versus just 3.4% with trastuzumab. And then the clinical pearl is this genotype of these F-allele phenylalanine amino acid at position 158 of CD16A gene. The median OS margetuximab was 23.7 months compared to 19.4 months in the control arm with marginal significance. And with that, I'll turn the podium over to my colleague, Dr. Gogineni, for the next presentation. Thank you.
Thanks, Dr. Pegram. Hi, everyone. I'm going to share with you some highlights from the past year in regards to the landscape of hormone-positive breast cancer. And while we didn't have any new drug approvals in the last 12 months, we did see quite a bit of data to try to individualize therapy and promising future directions, including emerging combinations in the adjuvant setting, some interesting information about first-line and post-CDK options in metastatic disease. And of course, all of us have had to think about how we're going to modify therapy for ER-positive patients in the setting of COVID. So the abstracts and the presentations that I'm going to focus on include PALLAS and MONARCH-E. Both of these studies were presented at ESMO this summer and looked at the use of adjuvant CDK inhibition in patients who had early stage ER-positive high-risk breast cancer. I'm also going to share with you some of the updated results from Next Monarch. This was a study that used abemaciclib monotherapy or abemaciclib in combination with tamoxifen in patients who were more heavily pretreated for their metastatic cancer. And then finally, we'll cover Parsifal and Believe. Parsifal was looking at the question of what's the optimal endocrine partner in combination with first-line CDK inhibition, and Believe gave us some real-world data about the role of PI3 kinase inhibitors after progression on CDK. Thank you. So let's go ahead and begin talking about PALLAS. Thank you. So PALLAS was a natural extension of the fantastic data that we had about CDK inhibitors in the metastatic setting. So investigators randomized a large number of patients in this phase 3 open label trial. And these were women who either had stage 2 or stage 3 hormone positive breast cancer. After surgery, they were randomized in a 1-to-1 fashion to either arm A, which consisted of palbociclib for 2 years combined with their standard endocrine therapy, versus an endocrine therapy alone arm. The primary objective for this trial was invasive disease-free survival. And to reiterate here, PALLAS patients had to have quote unquote high-risk disease. So they either needed to have at least 4 nodes involved, or if they had 1 to 3 nodes involved, other risk factors such as a T3, T4 tumor or high-grade disease. This is a slide just to reflect on a few selected AEs that were reported. Nothing surprising here. This is similar to the profile that we've seen in the metastatic setting, in which a large number of patients experienced neutropenia, however, minimal febrile neutropenia. Importantly, however, on the combination arm in PALLAS, there was a 64% discontinuation rate of palbociclib due to AE. And unfortunately, in January, the results were first announced that there was no difference in these 2 arms. At ESMO, the results of the planned second interim analysis looking at futility and efficacy were presented, and we did not see a difference in the combination arm in either invasive disease-free survival or distant relapse-free survival after a median follow-up of almost 2 years. Now, MONARCH-E investigators also presented their data this summer at ESMO. Similar to PALLAS, this involved patients with high-risk early-stage ER-positive breast cancer. They were randomized in a 1-to-1 fashion to abemaciclib 150 dosing twice a day for 2 years in combination with endocrine therapy or endocrine therapy alone. And we saw very different results with MONARCH. We did see a statistically significant difference in the combination arm compared to the endocrine therapy alone arm. Invasive disease-free survival was reported at 92%, and in the endocrine therapy alone arm, 88%. This represented a risk reduction of almost 25% in the invasive disease-free survival events and 28% in distant relapse-free survival events, which isn't shown here. I'd note also that there's an early separation here of the curves, suggesting that maybe abemaciclib has some role in intrinsic resistance in these tumors. Thank you. And just a moment to reflect on the AEs noted in Monarch E. Not surprisingly, as we knew with the role of the drug in the metastatic setting, we see more grade 3 diarrheal events, less neutropenia than palbociclib and ribociclib. Interestingly, fewer arthralgias and hot flashes in the combination arm. And of note, events of special interest, increased rates of VTE and ILD in the combination arm. Now, we didn't see meaningfully different results with these agents in the metastatic setting. So why are we seeing this in the early stage setting? There's a couple of potential explanations here that may have to do with trial design and patient population. Notably, the population in Monarch E was a little bit more high risk. Nearly 60% of those women had at least 4 nodes that were positive, and this represented a 28% greater rate than in Pallas. There was also a much higher dropout rate in Pallas. This might have been because we had more follow-up in Pallas, median of 2 years relative to the 15.5 months in Monarch E. But there was 42% of patients that dropped out in Pallas compared to 16.6% in Monarch E. And if you're not taking the drug, we're not going to be able to see the effect. Is there an actual difference in the drugs themselves or dosing? The fact that we give abemaciclib in a continuous fashion, and we're able to do that because of the less neutropenia. But also, is there something to there being more potent CDK inhibition with abemaciclib? Longer follow-up of Monarch E and Pallas will be important. We're also awaiting results of NATALY, which is a similar trial, but using the agent ribociclib in the adjuvant setting. TRIO investigators did actually modify the eligibility criteria for NATALY because of these results from Pallas and from Monarch E to include a higher proportion of high-risk ER-positive patients. Let's move on to thinking about agents in the metastatic setting and new data from this. So there was updated presentation of overall survival results of Next Monarch at ESMO this summer. Recall that this was a study that took patients who had been relatively heavily pretreated for their hormone-positive metastatic breast cancer and randomized them in a 1-to-1-to-1 fashion to either abemaciclib at a dose of 150 Q12 with tamoxifen, or abemaciclib monotherapy at a dose of 150, or abemaciclib at a dose of 200 with prophylactic antidiarrheals. And the overall survival results were significant. Note that the study hadn't originally been powered for overall survival superiority, but we did see that in the combination arm with tamoxifen, after a follow-up of 30-some months, that there was 24-month overall survival relative to the 17-month overall survival seen in the abemaciclib monotherapy arm at a dose of 200. And importantly, in the pre-planned subgroup analyses, we see that it seems like the combination arm has more benefit, perhaps in the setting of visceral disease. So let's move on to Parsifal. Parsifal was a study that tried to address the question of whether there's an optimal endocrine partner in the first-line setting. This was presented earlier this year at the virtual ASCO meeting. Previous data from Falcon and the SWOG studies had suggested that in an endocrine naive or sensitive population, that perhaps fulvestrant was a better agent than AI. So in this protocol, they took patients who were either de novo metastatic or who were endocrine sensitive, and that was defined as a relapse-free interval of at least 12 months from their adjuvant course. These patients were randomized to receive palbociclib with either fulvestrant or letrozole. And the primary objective of PFS, we saw no difference in the two arms. This was not a statistically significant difference between the two arms, designating the fact that we have a choice here in the endocrine naive or de novo setting. Lastly, I wanted to review some information from Believe. This was also presented at ASCO this summer, and this was sort of a real world representation of whether or not PI3 kinase inhibitors have activity after progression on CDK. SOLAR-1, which had led to the approval of alpelisib in combination with fulvestrant, had fewer patients who had actually progressed on CDK inhibitors. This was an abstract presented by Dr. Rugo. And in this trial, about 127 patients had been randomized to 3 arms. The arm that was presented at ASCO was the one that combined alpelisib with fulvestrant after progression on prior CDK. Thank you. And the results showed that they met their primary endpoint. 50% of patients were alive without progressive disease at 6 months, and there was a median PFS of about 7 months. This is in comparison to some data that had been reported from the Flatiron database. Within Flatiron, there were about 100 patients who had previously received CDK inhibitors who had a PI3 kinase mutation that went on to get a range of therapies. Median survival in that setting was about 3 months. Now, there were fewer discontinuations of alpelisib in the study compared to SOLAR-1, which had suggested some better management, anticipatory management of the real side effects of hyperglycemia and diarrhea. And so we await further follow-up from Monarch-E and Pallas and look forward to seeing what the results from Natalie tell us about the role of adjuvant CDK inhibitors. Also in the early stage setting, we're eagerly awaiting the results of what the role of the genomic score, 21 recurrence score, is in the setting of node-positive patients. And then looking for more data coming up about the role of drugs after progression on CDK in the metastatic setting, namely the role of AKT inhibitors and SERDs. Lastly, I just wanted to spend a minute on thinking about how we've changed management of hormone-positive breast cancer in the era of COVID. There's been a series of data published about mortality outcomes for patients who are symptomatic and who have cancer, and that higher mortality rates are seen. There's been a lot of organizations and institutional guidance issued about how we might reduce the risk of our therapies for these patients while COVID continues to be an issue. One of the published sets of recommendations came out of Dana-Farber, and specifically in the context of ER-positive breast cancer. The themes that we see here are thinking about, in the neoadjuvant setting, relying more on endocrine therapy as opposed to cytotoxic. In patients who we feel that there is a need to proceed with cytotoxic, thinking about ways that we can really modify the risk of that, i.e., is anthracycline really necessary, increasing use of growth factors, expanding the use of genomic testing such as Oncotype to try to reduce the usage of chemotherapy. So populations perhaps where we were more, had less data, but also a little bit worried about risk, thinking about younger patients with lymph node positive disease. Hopkins' recommendations were very similar. I would note that in general, patients who are getting neoadjuvant endocrine therapy who then go on to surgery, and then at the time of resection, the decision is made to pursue genomic testing. Recommendation has been to try to perform that genomic testing on the core specimen as opposed to the resection specimen, due to the concern the downregulation of ER and PR is going to result in a higher risk recurrence score. Lastly, at our own institution, we're doing things that I'm sure are being done across the country. Patients are being contacted prior to their appointments for symptom screening. Patients are again screened at the door with temperature and questions. We're minimizing visitors, which can be hard on patients. A lot more telemedicine. We are certainly relying on more endocrine therapy and expanding the role for genomic testing outside of the populations that we were ordinarily comfortable with. And we are trying to minimize the use of anthracycline. I would note also at our public hospital that there's a protocol in place to test patients with cancer who are undergoing highly immunosuppressive chemotherapy who aren't exhibiting symptoms, but screening them for COVID with PCR. Thank you.
Thank you. Good afternoon. My name again is Foluso Ademuyiwa, and I'd like to thank the organizers for inviting me to discuss the most exciting updates in triple-negative breast cancer. So just as a brief overview, triple negative breast cancer is seen in about 15% of all breast cancer cases. And we know that it disproportionately affects younger and as well as Black women. And historically, due to the lack of ER, PR, and HER2, we had relied on chemotherapy as systemic management until recently when we saw the advent of checkpoint inhibition, as well as antibody drug conjugates in the metastatic patients. And perhaps the immune checkpoint inhibitors will be approved very soon for the early stage patients as well. So this graph here shows that for triple negative breast cancer patients versus those patients who do not have triple negative breast cancer, the risk of recurrence is really within the first couple of years after diagnosis. And certainly after 5 years, the risk of recurrence really goes down for those CNBC patients. So I'm going to talk about some of the key studies in the metastatic setting as well as the early stage setting, and kind of really set the stage for what has led to the recent approvals. And so Impassion 130 has already been published. This was a large phase 3 randomized trial for patients with advanced triple negative breast cancer in the first line setting. And patients received nab-paclitaxel with or without atezolizumab. The randomization was 1-to-1, and treatment was until progressive disease or unacceptable toxicity. The co-primary endpoints for this trial were progression-free survival, as well as overall survival in both the intent to treat and PD-L1 populations. So looking at the final PFS results, which have already been published, in the PD-L1 positive subpopulation, we saw that the addition of atezolizumab improved the median progression-free survival, and it was 7.5 months in patients who received atezolizumab versus 5 months in the placebo-treated patients, with a hazard ratio of 0.62. And also, the 1-year progression-free survival was 29.1% versus 16.4% in those patients who received placebo. So very positive results. And most recently at ESMO, the overall survival results were presented. And if you look at the PD-L1 positive cohort, the median overall survival for those patients who received atezolizumab was over 2 years, so 25.4 months versus 17.9 months in the placebo-treated patients. Again, the hazard ratio here was quite impressive, 0.67, and there was no difference in the PD-L1 negative cohort. The median overall survival for both the atezo-treated as well as the placebo-treated patients was about 1.5 years, 19.7 months. So Keynote 355 was a study looking at pembrolizumab given with a variety of chemotherapeutic agents, again in advanced triple negative breast cancer patients. So the options for chemotherapy included nab-paclitaxel, paclitaxel, or gemcitabine with carboplatin. And the randomization was a 2-to-1 randomization with or without pembrolizumab. Again, patients were treated until progression or toxicities. So the progression-free survival results have been presented recently at ESMO and showed very similar results as the Impassion study. Again, for patients who received pembrolizumab, the median PFS was 7.5 versus 5.6 months for those patients who received placebo. And if we look a little bit more closely at those patients who are PD-L1 positive, as defined by a combined positive score of at least 10%, the median PFS was more remarkable in those patients who received pembrolizumab, 9.7 months, so almost 10 months, versus 5.6 months in the patients who received placebo and chemotherapy. And so I think based on these two large randomized studies, it's safe to say that both atezolizumab or pembrolizumab with chemotherapy both improve progression-free survival in PD-L1 positive first-line advanced triple-negative breast cancer patients. We also saw that there's an overall survival improvement with atezolizumab. However, the data is not yet mature for those patients on the Keynote study who received pembrolizumab. I also did want to mention that we saw the results of the Impassion 131 study, which was negative with chemotherapy being paclitaxel rather than nab-paclitaxel, which was on the original Impassion the original Impassion study. And so here, adding atezolizumab to paclitaxel did not improve progression-free or overall survival in either the PD-L1 or the intent to treat population. I also did want to mention about the PD-L1 testing, which can be different depending on the checkpoint agent. So with atezolizumab, the antibody we're using is the SP142, whereas with pembrolizumab, it's the 22C3. And the cells evaluated are also different, as well as the positive criteria being greater than 1% with atezolizumab, and with pembrolizumab, we look at the combined positive score. So this is the last study that I'm going to talk about in the advanced setting. This was a single-arm open-label study evaluating sacituzumab govitecan. So this study was actually part of a larger study looking at this agent in advanced epithelial cancers. This was a phase 1-2 study. And the cohort of patients that had triple-negative breast cancer was about 110 patients. And here they received single-agent sacituzumab govitecan until progression or unacceptable toxicity. And I think we've all seen this waterfall plot, which is very impressive. And so this showed that many patients treated with this agent derived clinical benefit. The objective response rate was well over 30%. And this is not something we usually see in triple-negative breast cancer patients who have been previously pretreated. Also, the clinical benefit rate was also very impressive, about 45%. So based on that study, the FDA granted accelerated approval for this agent in patients with triple-negative breast cancer who have received 2 prior lines of therapy in the advanced setting. And ASCENT was a phase 3 confirmatory study, which was also recently presented at ESMO. And so here are patients with advanced triple-negative breast cancer who had received at least 2 prior therapies for advanced disease were randomized in a 1-to-1 fashion to sacituzumab govitecan given on days 1 and 8 every 21 days versus a variety of chemotherapeutic options. And here the chemotherapy options that were allowed included eribulin, vinorelbine, gemcitabine, or capecitabine. So the primary endpoint here was progression-free survival measured by an independent, centralized, and blinded group of radiology experts. And other key secondary endpoints included PFS for the full population, overall survival, objective response rate, duration of response, time to response, as well as safety. So these are the top line results. The progression-free survival was quite improved with sacituzumab versus chemotherapy, with a median PFS of 5.6 months in those patients who received the investigational agent versus 1.7 months in the patients who received chemotherapy, with a quite impressive hazard ratio of 0.41. But I think more importantly are the overall survival results, which were quite impressive. So those patients that had sacituzumab govitecan had a median overall survival of over a year, 12.1 months, again, which is not something that we usually see with pretreated triple-negative breast cancer patients. And those patients who received chemotherapy had a median overall survival of 6.7 months. And the hazard ratio here again was 0.48. So with this agent, we do see side effects. Specifically, we see heme toxicities, particularly neutropenia and anemia. There can be some GI disturbances as well. Diarrhea can be seen as well as nausea and vomiting. And then fatigue is seen with this agent, as well as alopecia in about 46% of patients. However, of note, there were no severe cardiovascular toxicity seen and no grade 2 or higher peripheral neuropathy or grade 3 interstitial lung disease. Notably, there were no treatment-related deaths with sacituzumab govitecan. There was one treatment-related death in the patients who received chemotherapy, and that was due to a neutropenic sepsis. And also there were very few treatment discontinuations on both arms. So on the sacituzumab treated patients, the discontinuation rate was 4.7 and 5.4 in those patients who received chemotherapy. So really can be well tolerated with proper management. So these are just some pearls for practical side effect management of patients who are being treated with sacituzumab govitecan. We can see some diarrhea, and one needs to be aware that about 20% of the population will have a different UGT1A1 variant, which can lead to profound and prolonged diarrhea as well as neutropenia. So if this is evident in patients you're taking care of, it might be worthwhile to check the UGT1A1 status and adjust the dose of sacituzumab govitecan accordingly. Otherwise, one can use a standard antidiarrheal agents to manage the diarrhea. With regards to neutropenia, daily filgrastim can be used after each dose, or better still, one can consider pegfilgrastim after the day 8 dose so that the patient can be ready for the next cycle. Antiemetics and dose reductions can be used to manage the nausea and vomiting. And there is a unique side effect of flushing, which can be seen in a small proportion of patients, which can be easily managed by atropine or hyoscyamine. So this is the only slide on early stage triple negative breast cancer because we really haven't seen any recent approvals in that space. However, some large randomized studies, specifically the Keynote 522, as well as in Passion 031, have recently read out. And so for the Keynote 522, which has been published, we saw that in the PD-L1 positive patients, the PCR rate approached 70% versus 55% in those patients who did not receive pembrolizumab. And similarly, in the Passion 031 study, again in the PD-L1 positive cohort, patients who received neoadjuvant atezolizumab with chemotherapy had a PCR rate of close to 70%, which is quite high, versus about 50% in patients treated with chemotherapy alone. So I think probably next year, we might be seeing some approvals for pembrolizumab and atezolizumab for use in our early stage triple negative breast cancer patients. So stay tuned for that. And then I wanted to spend just 1 minute talking about remote and virtual care. So due to the advent of COVID, we've had really a rapid transition to telemedicine visits for many of our eligible patients. I did want to mention that there is a difference in telehealth and telemedicine. So telemedicine is a small part of telehealth, which really encompasses the utilization of electronic information and telecommunications technologies to really support and promote long-distance healthcare for patients, as well as patient and professional health education, public health, as well as health administration. So there were 3 COVID-19 federal stimulus packages that were made available to really address telemedicine, which made it much easier for us to provide this as an option for our patients who are eligible. And so what we did was that patients who are stable on observation, long-term patients who are on a stable dose of endocrine therapy, as well as patients who had established medical oncologists in their home cities who wanted second opinions, and post-op patients who were stable and didn't have any complications were really appropriate for telemedicine. We also put more reliance on local laboratories for blood draws so that we could monitor patients close to home. And we also do need to be aware that there might be some privacy and security concerns down the line, but we haven't had any issues with that to date. And we also saw that, continue to see that there's a higher patient and provider satisfaction with telemedicine. And so in summary, sacituzumab govitecan was approved in April for advanced triple negative breast cancer patients following at least 2 lines of systemic therapy in the advanced setting. And there might be some new indications in the horizon for 2021, atezolizumab and pembrolizumab, both for neoadjuvant triple-negative breast cancer, and pembrolizumab also possibly for advanced triple-negative breast cancer based on the KEYNOTE study. And then virtual visits are feasible, they're effective, and also associated with high patient and provider satisfaction. So thank you for listening.
Hi, my name is Valerie Mitchell, and I am a breast cancer survivor, a wife, a mom, and a licensed professional counselor. Thank you for giving me the opportunity to share my story, making the best of it and taking the lead. Taking the lead in my treatment was not something familiar to me. My personality tends to defer to the experts and trust their judgment. My breast cancer diagnosis shifted my perspective. I had a mammogram in January of 2016 that included an ultrasound and 3D imaging. I was given the all clear, see you in a year. But just 4 months later, I found a golf ball sized tumor in my armpit that was linked to a 2-centimeter tumor in my breast. A few days later, on April 15th, tax day, I got the call that every woman dreads. You have cancer. I had invasive ductal carcinoma, HER2 positive, grade 3. The radiologist that initially gave me the all clear didn't mean any harm. She just missed it and made the wrong call. But this oversight could have cost my life. And that began my journey of realizing that no one knows my body better than me, so I better start paying close attention and speak up. Following diagnosis, one of the first calls I made was to a friend who had breast cancer a few years prior to me. We were in the same profession, and I had questions about how she handled the business side of things. And she was happy to answer my questions, but more importantly, she linked me to Here for the Girls, a support group for young women with breast cancer. I was fortunate to find this group at the beginning of my cancer journey. The group motto is "Live life with an exclamation point." This picture is just a few of the hundreds of women who are part of this organization. The support group helped by answering questions from the perspective of someone who had been in my shoes. They provided some fun activities along the way, and they were there during some of the most challenging times. Next slide. Like many cancer patients, I was encouraged to cut my hair to prep for chemotherapy, being reassured that emotionally this would be easier than having it fall out. My family offered to be a part of this, but they were already coping with so much. I wanted to spare them, but I didn't want to go it alone. The girls from the support group gathered with me that day, bringing champagne, flowers, lollipops, and music. I decided to have a little fun with it and go with a mohawk first, hoping that this would be the only time in my life that I will sport a mohawk. Being HER2 positive, chemotherapy was my first treatment protocol. I underwent 6 infusions of Herceptin, Perjeta, Taxotere, and carboplatinum every 3 weeks, graduating chemo the last week of August in 2016. It was a hot summer and not a bad time to be bald. Next slide. The next step was surgery. While I was assured that a lumpectomy would address the cancer, I opted to have a bilateral mastectomy. The cancer was in my right breast, but an MRI found several suspicious spots in my left breast. My goal was to avoid any future recurrence of breast cancer, so I opted to have both breasts removed. I had a series of several surgeries every 3 months that included reconstruction. Next slide. The third phase of treatment was 28 days of radiation. This is a stock photo because I didn't have any pictures for me personally. It is fitting because this was the loneliest phase, as no one was permitted in the room for their own safety. I had to find a coping skill to keep anxiety from getting the best of me. And throughout this journey, many people were sending happy vibes and prayers my way, so I decided this was a chance to return the favor. I asked for prayer requests and made that a special time to just lift others up while the radiation machine did its job. Next slide. I rang the final treatment bell in May of 2017, which included a year of infusions with Herceptin. I was excited to be finished and have some hair growing back, but I wanted to know how to prevent a cancer recurrence. There is a lot of information out there in the Googleverse about cancer prevention, and it can be difficult to sort out the fact from the fiction. When I approached my doctor about preventing a recurrence, I was told to exercise, follow a good diet, maintain a healthy weight, avoid alcohol, and don't smoke. All of the things I was doing when I got diagnosed, and this was unsettling. Once active treatment is finished, many survivors begin the next phase of healing, recovering from the emotional experience of a cancer diagnosis, trying to figure out what caused the cancer in the first place, coping with everything the body has been through and the side effects, rebuilding a new normal in life, and the biggest part for many, managing the fear of recurrence. One of my coping strategies was to monitor for any new developments in HER2 treatment. Next slide. One July morning, I was checking the Here for the Girls Facebook page, and I found a post about a new drug that was just approved to prevent recurrence in HER2-positive breast cancer. I was excited to talk with my oncologist about Neuralinks. However, she was not so enthusiastic. She was worried about the side effects, especially diarrhea, and she did not want to prescribe it. I wasn't too worried about the diarrhea because I'd already faced chemotherapy, and I figured it couldn't be much worse than that. I decided to get a second opinion. It was hard to question my oncologist's recommendation. She had been with me through some of the most difficult days of my life. But what helped me to do that was knowing that this is my one and only body, and it really is a life and death decision. I wanted peace of mind to know that I explored every option available, and I didn't want to look back one day and say, what if? Doctors make the best effort to give effective recommendations, but they have hundreds of patients. I have just one body, and I need to be sure that I'm taking care of that and taking the lead in my healthcare. The new oncologist supported my request to take Neuralinks, and I started it in August of 2017. I was her first patient on this new medication, so we kind of figured it out together. There were side effects, and the diarrhea is no joke, but I still managed to go about building my new normal life. I returned to doing the things I love, plus added a few new adventures and traveling to places I dreamed of visiting. Next slide. I finished taking Neuralinks on Thanksgiving Day 2018, and I had so much to be thankful for. Next slide. At the top of my gratitude list is a wonderful husband who walked the journey with me. I clearly recall one evening early in my diagnosis when I laid on the floor sobbing, tears forming a puddle below me, terrified about the unknowns of the future and if I would survive. He comforted me by sharing, I don't know what the outcome of your treatment will be, but I can promise you, you will not do it alone. I am very fortunate to have his support every step of the way. Next slide. This year with the COVID epidemic, I've had a chance to give back some of the support that he gave me. Unfortunately, he is one of the people who suffers with the long-term side effects of COVID. Being 4 years into recovery, I am on a 6-month check-in cycle with my doctors. COVID did not interfere too much with my care. I know that it has not been the case for a lot of women who are newly diagnosed. So to prepare for today's discussion, I checked in with some of the girls from my support group, inquiring about how COVID had influenced their cancer journey. And they shared several examples. First, an increased sense of isolation, not being able to have family or friends with them during doctor's appointments, chemotherapy, and pre-op and post-op surgery. They also shared some reduced support from family and friends. People were worried about disease transmission and infecting somebody with a reduced immunity. Another concern was getting regular screenings and access to medical care. One of the girls had expressed that her surgery was delayed early in the pandemic as hospitals shifted gear to prepare for an onslaught of COVID patients. She struggled emotionally knowing that the cancer remained in her body as she was waiting for the surgery center to reopen. These are just a few examples of the impact of COVID on breast cancer treatment from the patient's perspective. Thank you so very much for inviting me to share my story and to be a part of this webinar.
Thank you very much, Valerie. That was a very moving account of your experience, and it really brings home all of the things that we strive for in clinical research is to make the lives of our patients better. That's what it's all about. Fortunately, it's been a good year in breast cancer research. There are many new treatment options for patients, as you've seen, with multiple subtypes of breast cancer, including HER2 positive, triple negative, and hormone receptor positive indeed. And I want to thank our speakers today for their brilliant summaries of the activities involving clinical research during the past year. It's been an exciting year. Perhaps the only good thing that happened in 2020 that I can think of was advances made in clinical research in breast cancer. So more to come. Next year will be even better. I know there are many new agents in development for breast cancer as we speak, and we're expecting results from those studies out in the next year or two. And I think there will be many more advances to come with even better outcomes, especially for early stage disease where we have potential to cure patients with breast cancer. I want to thank our listeners for taking time out of your very busy schedules to consider this presentation today. I also want to thank our sponsors once again at Total Health for helping us to get this session together this afternoon, and look forward to giving you future updates as data evolves. Thank you very much for your participation.